Everybody. So today I'm just going to go through a random smattering of papers. The first two are just like quick ones. So this first one is on Biobot analytics and their wastewater methodology. This I think might also, no, this is a different thing. But that's what we're going to start with. So this is Biobot's analytics quote unquote white paper. So they're looking at effective concentration, a future-proof approach to characterizing pathogen concentrations in water. So the effective summary, this is like their brief bullet point notes. Wastewater-based epidemiology is an important tool for monitoring COVID-19 activity. In fact, the raw concentration of COVID as measured in wastewater is affected by technical factors unrelated to the spread of the virus. So this can be things like how recently the wastewater was changed over, how long it sits, if you're sampling supernatant liquid versus the solid concentration that like sort of piled at the bottom. There's a special word for that, but I'm spacing on it right now. Storage conditions, how quickly you took the sample, brought it to the site, to the testing facility and tested it. These are all different types of things that can influence it. So that's what they mean when they mean technical factors unrelated to the spread of the virus. Currently, Biobot uses normalization to adjust for dilution and population size. So normalization, they use the pepper mild model virus, PMMOV. That's how they normalize. That's a really good normalization factor because it's something that grows in all wastewater facilities. And they found that when you divide essentially the N gene concentration by that number, you're able to compare across different wastewater facilities. So that's something that Biobot and a lot of other facilities have taken up. And then Biobot does some sort of technical adjustments beyond that dilution population size. I'm not sure what they're referring to there, but we'll figure it out. So they're introducing the concept of effective concentration as a transparent future-proof approach. So that's what we're going to focus on. It's the big one for this. Presenting the effective concentration rather than ever-shifting method-specific nomenclature will allow us to continually improve our methods without affecting customer data interpretation. So the raw concentration of COVID in wastewater is affected by factors unrelated to the spread of the virus. In COVID wastewater epidemiology, the key measurements is the concentration of COVID in wastewater. So this is typically the viral RNA copies per milliliter or the N gene copies per milliliter. At Biobot, the concentration is measured using qPCR, quantitative polymerase chain reaction, and reported in the units of genome copies per liter of water. For clarity, refer to this value as the raw concentration. The raw concentration of a sample is the starting point for many applications of wastewater-based epidemiology. However, the raw concentration is subject to factors that are not relevant to COVID disease activity, such as dilution of the wastewater due to precipitation or other inflow. So like these are good other things. So like rainfall can influence it by diluting the wastewater. So you have essentially more liquid than you would typically otherwise have, which dilutes the concentration, which makes it so that per milliliter, per liter in this case, you have less virus sample. So it's like an artificial decrease. Changes in the size of population contributing to the sampled water. So like if you have a bunch of people come in from out of town for some sort of activity, and then all of a sudden your wastewater spikes, and then all these people disperse and go back to where they came from. Changes in wastewater flow rates due to changes in water usage pattern. So that would be another thing that's related straight to that, like when you have different types of population flows. Temperature and time-dependent degradation of the virus in the water. So yeah, that's another good factor. Recovery, efficiency, proportion of the virus in the sample to the laboratory sample preparation process is able to capture quantification. So again, that's going to be related to where you're sampling. Are you sampling from the liquid of the waste? Are you sampling from the solids of the waste? So that's also a good one to mention. PCR inhibition the possibility that chemicals in the wastewater sample affect the laboratory's method's ability to measure the viral concentration. I'd have to learn more about that. I'm not sure what types of chemicals in the wastewater. So I think I might understand actually. So I think what they're saying is like generally wastewater facilities will treat their wastewater with chemicals to make sure it doesn't smell, because obviously it's going to give off a very pungent, powerful smell. So those chemicals, if they treat it right before you sample, that could impact the virus. It could kill off virus, which would cause your sampling, your true virus per liter sample to go down. Other differences in laboratory methodologies used to measure the virus. So yeah, this is just like every lab will have their own set of methods. Some are going to be performing better than others. So that's going to impact it, and that can also play a factor in like storage conditions, things like that. Boom. So the normalization. So now we're going to learn about the normalization that Biobacter does to account for dilution, population size, and wastewater flow. The common practice is to normalize COVID concentration. There are two methods. So raw concentration, flow rate. So they're just defining the variables in this little guy right here. So we have flow rate, population size. So they're doing flow rate times raw concentration divided by population size. So I guess the thing would be the, so I guess, let's see. So if we have a high flow rate, and so if we just look at the flow rate, so if we have higher flow rates, then we're going to have a higher impact on this normalized concentration. If we have a lower flow rate, it's going to decrease it. If we look at population size, the larger the population, the smaller the concentration. The smaller the population, the larger the concentration. If we look at raw concentration, the higher the raw concentration, the higher the normalized concentration. So that's interesting. So I guess that's an okay normalization. And then use the raw concentration and the concentration of fecal strength indicator virus to compute the normalized concentration. So I think the fecal strength indicator, yeah, is the pepper mild model virus, PMMOV. So, oh, actually it's not. So they're doing this first, and then they're doing a further correction, or not correction, normalization. So you have a reference concentration times the relative concentrate, or the raw concentration over the fecal strength indicator. So what is this fecal strength indicator is my question. So the pepper mild model virus is the fecal strength indicator. Okay, so yeah, so this is literally just saying the raw concentration divided by the fecal strength, divided by the pepper mild model virus. Partners call in. Good morning. One sec. I'm gonna pause real quick and take a phone call, but I will be right back in less than 5 minutes. Let's see. Pause. That was a lot faster call than I thought it was going to be. Good morning. So we're just looking through. I'm just going to do a random smattering of papers that I have saved because my partner is out of town. So I can literally just do a little COVID binge session where I learn a bunch of stuff from my file of papers that I need to read, and then I can throw it into Red, which then I can make videos off of. and I can put new papers that I've saved in my bookmarks into the folder. But yeah, so that's what we're doing. We're just cranking through random papers. Right now we're going through the Biobot white paper and how they analyze their data. And it's kind of interesting. So I don't know what they're using as the reference concentration. That's interesting because I already knew about the normalization by the pepper mild model virus, which I think is a very good correction factor. But I'm not sure what the reference concentration is. I'm hoping they tell us later in this little white paper. But they're doing two normalizations. So they're normalizing for, they're doing corrections based off of the raw concentration, the population size, and the flow rate. So the only one I'm not sure about is the flow rate. I agree that the population size should be a correction. Because like then you can compare smaller populations to larger populations. Because if you just like think about it like big picture, if you have a very large population, you're going to have more COVID in the population. So how can you compare that population to a small county? Well, you need to correct for it. So like that makes sense, but the flow rate I'm not 100% sure about because it makes sense that if the flow rate is moving faster, you're going to have less COVID sampled in because you have a much faster turnover. So the COVID's not going to be settling and staying in as long as it would otherwise. So they're up adjusting for that. So if you have very, very high turnover in your flow rate, where it's just moving very, very quickly, then they're compensating for that, which makes sense. But like, I don't know. I have to sit and think about that one more. I don't like that they're just doing a strict multiplication factor. I feel like there should be like some sort of normalization, like I don't know. It's tingling my data senses. I think it's not a great. It's good. It's not great, I guess is the way to say it. And then the next thing is this initial concentration value that I'm interested in. So both methods, yeah, she just texted me, are designed to adjust for the raw COVID concentration measured as a sampling point to better approximate the amount of virus contributed by people represented in the wastewater sample. The first method accounts for the dilution that occurs. Yep, that makes sense. Between the point of excretion and the point of sampling. And it accounts for varying population size. 100% agree. The second method assumes that the fecal strength indicator is excreted at some fixed population average per capita rate, so that the concentration of the indicator at the point of sampling accounts for both dilution and varying population size. If the fecal strength indicator has similar biophysical properties as the target, then the second method also accounts for recovery efficiency. If the laboratory sample preparation method has similar recovery efficiencies for the two viruses, then taking the ratio of the results account for the recovery efficiency. Yeah, that makes sense. But where and why are you multiplying this by an initial concentration value or a reference concentration value? That doesn't make sense to me. So hopefully they do address that in this. Good morning. And then ideally, as the field of wastewater-based epidemiology advances, more of the factors affecting raw virus concentrations in wastewater can be accounted for. Normalization was an important step, accounting for some key factors affecting the public health interpretability of wastewater measurements. Future improvements will include accounting for differences in measured virus concentrations that would result from updating or changing the laboratory protocol. So that's just a fancy way of saying, hey, we recognize that every lab is going to do things slightly differently. We need to create a standardized method that all the labs do so that we can sort of account for this interlab variability, which is something that would, that's a fun username, Lizard, that would count for this interlab variability. So they're just saying, hey, that's something we need to do. However, the resulting updates to the terminology will be quickly become cumbersome. Normalization is a single term with two well understood meanings amongst wastewater experts. Degradation adjusted concentration is clear and brief enough, but concentration adjusted for laboratory protocol. Differences in viral concentration is a mouthful, while adjusted concentration is too vague. So this is going to sound like semantics, but essentially they're saying, hey, we recognize that saying normalization, like we're using the word normalize a lot, we have two different methods that can compensate for normalization. We think that you need to do both methods to properly adjust for this and to be able to compare between very large places, very small places, and different wastewater facility variables. This is what we think that people should be doing, that are going to be looking at fecal strength and all this other stuff. But we recognize that we're using similar terminologies for two very different things. One accounts for population and wastewater facility variables. One compensates for just like specific variables for each wastewater facility. But we're using the same word, normalized, and we don't want people to get confused and just do one and not the other. We want people to do both, is essentially what they're saying. So they're trying to come up with a unified language so people know how to speak about both things so that there isn't confusion, which is why they're introducing the term effective concentration to refer to the raw COVID concentration adjusted for all factors. So that makes sense. So they're going to say there's the raw concentration, there's the normalized concentration, and then there's the effective concentration. So for example, we continue to update and improve our laboratory protocols and operations, and any update to a protocol means that the same wastewater sample will yield different raw concentration. During a protocol change, we measure the same wastewater samples of both the previous and new protocols. Using the resulting data, we derive an adjustment factor that accounts for differences in measured concentration due to the protocol change. The effective concentration of the sample measured using the new protocol will then reflect the concentration that would have been measured using the previous protocol. So they're whenever they do a protocol change, they're comparing it to what values they would have gotten in the past to make sure that they're compensating for that and that there's not significant differences, so that they can look back retrospectively and be like, yes, our new method is comparable to our old method. It's not different enough that we can't compare apples to apples, and then all of a sudden it's apples to oranges, is what they're saying there. And then more broadly, Biobot intends for the effective concentration to be formulated such that trends in effective concentration do reflect trends in population-wide COVID burden and do not reflect technical artifacts like differences in lab protocols. So yeah, that's basically what we've been talking about. And then they're saying the effective concentration will not be a black box. So black box, this is a concept where it's basically used in artificial intelligence a lot. Oh, I forgot my camera's up there. It's used in artificial intelligence a lot, where you have some sort of system where you don't really know how it works. You have inputs that you throw into the system and you get an output, but this is what we know. This is what we got as a result, but we don't really know what's happening in the mix in the middle of it. So that's the concept of a black box, because it's like we know that something happens, we just don't know what it is, which is the black box. It's like an unknown. So when people are saying that, they're saying we don't want it to be a black box. We don't want it to be something that is just like vague, like it works, just trust us, this is how it is. They want it to be transparent. They want people to understand why they're doing things the way they're doing it. They don't want people to just be like, oh, this is just Biobot doing whatever they're doing. They're trying to be, again, transparent with how their wastewater analysis is. And then they're saying that our goal is to allow technical experts to scrutinize the raw data while providing a seamless data stream to users, focus on public health implications of that data, so that an analogy feels like temperatures. We chose the term effective concentration because it was not specific to any methodology. This approach was inspired by the feels like temperatures reported by consumer weather services. So like that's just referencing like So we know that the weather outside is 60 degrees, but it feels like 55 with a wind effector, whatever is what they're referencing there. So the raw temperature measured in degrees is the most important number for understanding how it feels when you go outside, but other factors like wind speed, there we go. Wind speed and humidity are important too. The wind chill temperature is computed using the raw temperature, and wind speed, the heat index, is computed using the raw temperature. Humidity, the combined indicator that accounts for both wind speed and humidity, is called feels like temperature. Just as feels like avoids clunky phrasing. Like, so this is just them using an analogy to be like, this is why we're saying effective concentration. It's their weather report. It's their feels like temperature. So we read that one. That makes sense. I like it. I don't understand why they have this initial concentration that they're multiplying by. They did not, in my opinion, adequately address that. Unless the reference no, it's a reference concentration. So doesn't make sense. But everything else makes sense. I just don't know where they're getting this reference concentration from. Because basically that's implying they have a lookup table. A lookup table is basically given like this factor and that factor, you cross-reference them on the chart, and then that's your reference number, and then you use that reference number to throw into something like this is what it implies, but they didn't really go into what that reference concentration is. Okay, so moving on to the next one. So this one was I don't know if I already read the papers from this dude or if they're still in here in my, I think they're probably these ones right here, which I'll probably read today. This guy had these really great papers, and he put out back in like 2021, I think. Let's see if there's a date on this somewhere. Not seeing a date, but I think it was back in 2021. He built this document together based off of the papers that he wrote, and he was saying like, we need a vaccine plus strategy. Like, vaccines are great. We need to make sure that our population is vaccinated, but we need to be considering other factors. That's the plus. Because a vaccine only strategy. Yeah, so this is, here we go, right in the first sentence, 2021. Vaccines only is not going to work. It's not sufficient. We need non-pharmaceutical interventions, NPIs, and that's sort of what it's talking about. So I just wanted to like go through and read through his strategy and thoughts from back then, because a lot of times like scientists do have a lot of like, they think deeply about things. They don't write stuff like this very lightly, especially when it's going to be proposed to the world. And I just wanted to like read through and be like, yeah, this is stuff that we could have implemented. This is how we can like move forward. Because people always ask, how do you move? Like, what are the next steps? How do we fix the situation? And like, I kind of view it like learned helplessness. Like when people get overwhelmed, they're just like, well, we can't do anything about it. And it's like, no, there's very specific things we can do. We just need to start working on them. Thank you. I don't know what you're thanking me for, but you're welcome. So going through this one, COVID-19, an urgent call for vaccine plus action. Come on. So I truly do love that phrasing, vaccine plus. It's very clever. So COVID has infected more than 278 million people globally, with at least 5.4 million deaths reported by the World Health Organization as of December 26, 2021. So again, this was written in 2021. So the Omicron variant of concern is spreading rapidly. B11529, I think that was Delta, if I'm not mistaken. So that was back during the Delta and BA1 variants. So some countries view infection as a net harm and pursue strategies ranging from suppression to elimination. They seek to sustain low infection rates through a combination of vaccine, public health, and financial support measures, which the author is defining as vaccine plus. So the vaccine is one part of the strategy, and then the plus part is investing in public health services and public health measures, and then funding those public health measures. So other countries implemented mitigation strategies that aim to prevent health systems from being overwhelmed by building population immunity through a combination of infection and vaccination. So that's the quote unquote herd immunity strategy that the US fully jumped into. And you'll see this all the time in articles where people are talking about, we have high levels of population immunity, whether through infection or vaccination. And we're finding more and more that that's just not true, because with every COVID infection, your immune system is being suppressed. And the new phrase that we're using to combat immunity debt is immunity theft. B11529 was the original Omicron strains as we were coming out of Delta. Okay, yeah. I can't always remember the exact ones off the top of my head because it's getting so large, but I forget. It definitely had a name, or maybe it was just called original Omicron. I always forget. Let me just Google it real quick. B.1.1.529 name. Yeah, so that's just original Omicron. Mabi. And that's sort of the strategy that the US undertook. So these countries rely on a vaccines-only approach and seem to willing to tolerate high levels of, and that's that's an very important statement. Make that green. So like the US is relying on a vaccines-only approach, and they're willing to tolerate high levels of infection with the belief that our healthcare systems can cope with this, that our economy can cope with this, that they've basically said it's okay that people get this infection, that they get this disease. We're willing to tolerate people being disabled. We're willing to tolerate people being harmed by this disease because we think that it'll all just blow over. Like Trump said, oh, you know, if you stop recording, the numbers will magically disappear. Like, in the past, a lot of times when you have emerging viruses, you could just ignore it because over time, people would get immunity and then the virus would just dissipate. That's not what happened with COVID, and it's not what's going to happen with COVID. It's only going to disappear if we have sustained, intense global efforts. But that's a very important statement that you have to recognize that like the government is willing to tolerate people being sick on the premise that they believe that the healthcare systems can cope with it. So the high transmissibility and degree of immune escape of the Delta Omicron variants means sustained protective population immunity is unlikely to be achieved with the current vaccines based on the original strain. Yep, so that's another good statement. And I gotta remember, this was written in 2021. So even back then, this expert in COVID is saying that like it's mutating so quickly, and with these variants and our vaccine targeted to just the Wuhan strain, we're unlikely to achieve protective population immunity to be able to make these viruses sort of just snuff out on their own. Where Omicron the original Omicron, B11529, it was much more likely to infect those. So that's a tricky statement. So when they say much more likely to infect those, they mean, so here we go. So that's the important part. Who were vaccinated or exposed to previous COVID variants, saying that it has immune escape. They're not saying it's more likely if you're vaccinated to get this. They're saying that because it has a sufficient mutations to provide immune escape, even if you're vaccinated, even if you've had previous COVID infections, it can still infect you. And that's sort of what we're seeing right now with the JN1, is that it has sufficient mutations to escape immunity. The CDC has said, and it's very clear because of how fast it's growing, that it has this ability to escape current immunity to what we have been immunized against, or for people that have been actually caught the virus and developed an immune response to it. It's far enough away again where we're not going to be protected against it. So like the vaccine's only strategy is not going to work. And that's what they mean by that. So yeah, here we go. Suggesting significant immune escape. And that's the important part. People always get tripped up on this language right here, but all they're saying is that it means that there's significant immune escape. So widespread transmission brings a degree of unpredictability to the pandemic response. So because so many people are getting infected, it's mutating even faster because it's a very unstable virus. And by the time we have got a new vaccine, or enough people have gotten sick that they have protection and immunity against it, that it's mutated again. So we're in the same situation that we started with. It's like you take one step forward and then 3 steps back. So high transmission risks and more rapid adaptation of COVID with outcomes that include increased transmissibility. So yeah, they're saying that we've seen increased transmissibility as the virus has mutated, and increased immune escape or greater pathogenicity. So they're sort of underpinning why the vaccine's only strategy is not going to work for all these reasons. 1 second, I gotta go take some Tums. I'm at the tail end of a gluten reaction and getting the acid reflux stage. Also, hi, Christina. We gain immunity to variants that we drive by and are in the rearview mirror chasing pavement. Yeah, definitely. Hello. And then, so they're saying that, like, basically we can't just rely on vaccination. We can't rely on immunity being developed from getting infected, because it mutates so rapidly and it's increasing in transmissibility, because like it wouldn't necessarily be as problematic if the transmissibility wasn't increasing. Were you saying that there was an issue with masks with a metal noseband? No. The only time there would be issues with masks with a metal noseband would be if you're doing like an MRI scan or some sort of procedure in the hospital. So that would be like when you would need a strapless mask. Are you referring to like a different video? Because we're talking about population immunity here. So yeah, so the increased transmissibility, because it's so we've seen that like over time you need less and less virions to get infected. So as the transmissibility goes up, and we're also having increased mutations going up, and increased mutations contribute to increased immune escape, that this vaccines only strategy wouldn't work. Wouldn't enter a hospital for Jack. Yes, sorry. Yeah, no worries. Never need to apologize. So there are other drawbacks to a vaccines only strategy. Countries which tolerated high transmission have seen rises in both COVID-specific and all-cause mortality, healthcare worker shortages, and repeat lockdowns to control surges in case numbers. Countries which suppressed transmission early saw reduced mortality and less economic damage. So outside of like, not only is it bad for people individually, it's also bad for global economies, which is what it's saying, and for healthcare in general, because if you have workers out that are sick, they're not going to be there to help people that are sick and injured. And then also, like, people are dying a lot earlier. And there's economic damages because people are going to be out sick from work, so they're not going to be contributing to the economy, which is a terrible reason, but for some people, that's like another thing. Family medical leave. Sorry to hear that. So while vaccination greatly reduces risks of serious illness and death, long COVID remains a concern. And that's the other thing, is that long COVID still exists. So like early studies, and the last ones I saw were from 2022, but like vaccination will reduce the occurrence of long COVID, but the numbers that I was seeing was that like back then, when it was earlier on, the percentage of people in the control group, the people that weren't vaccinated that were getting long COVID, was like 11%. And then the people that were vaccinated getting long COVID was 8%. So it was only like a 4% reduction. So it does reduce it, and we've seen consistent studies that show that this risk is reduced, but it's not eliminated, and it's not really being reduced by that much. That's not to say that you shouldn't get vaccinated. Any risk reduction is always very beneficial, it's always very good, but it's not going to prevent long COVID, is like the underpinning thing. And then disruption to education as a result of staff and student sickness, so that's like another thing. And or repeated lockdowns due to failure to control the virus are likely to have lasting impact on the well-being and prospects of the next generation. Not to mention like the repeated infections and the brain damage it has on developing minds. Like, what is that going to do in the long term? We have no idea. Yes, it's a mass disabling event, not great for the economy. Yeah, not great for the economy, not great for societies, not great for long-term people. Like, I a while ago, as a quick aside, I was thinking about like the movie Idiocracy, and I was like, if you haven't seen it, basically like in the future, this one guy from the current time has average intelligence gets transported to the future where everyone's really dumb, and like he gets sent to prison because he doesn't have like a pass or something, and it's basically like fitting blocks in a hole, and people can't do it, and then he does it, and like he is officially like the smartest person on earth. And like the reason that they gave for this is because smart people just didn't have kids because they were too busy with life and being successful and smart. But like when you have like a mass population disabling event with significant brain damage being a complication, because that's what we've been finding is that COVID will damage your brain, then it could quickly devolve in a couple generations to something like that, where we just have like a highly developmentally damaged population. That's like the video I did about olfactory memory too. Yeah. And it's like, well, that would be a crazy scenario. Yeah, I don't know. It was just a weird tangent aside that I was thinking about. So high levels of transmission also create a negative feedback loop whereby important public health measures systems such as test, trace, isolate, and support systems become overwhelmed, making them less effective. And right now, we do not have a test program, we do not have a trace program, we do not have an isolate program, we do not have support systems. So when people are telling you that we have the tools, we don't have them anymore. People can't really afford PCRs, rapid tests have become dramatically less effective. We don't have contact tracing anymore. They disabled all those things on our phones that we did have, and no one's really doing that anymore. Isolating is not sufficient anymore in terms of how the disease has evolved. By days 3 to 5 after symptoms, you're peaking your viral load, and by day 5 you're back to work. So the isolating guidelines are completely insufficient. We don't have support systems. People can't take time off of work anymore. A lot of times if you're sick with COVID, people have bosses and employers have been telling people to come in. So literally every single thing in this list is no longer something that exists. We don't have anything. Yeah, it's true, we don't. She's vaccinated and used to mask, but they relaxed too much since late 2022. I'm sorry. Which further fuels transmission. And yeah, I still think we're going to hit all-time highs this winter. I think we're going to surpass the highs from 2021-2022 period. And for all these reasons, and again, this is in 2021 that they wrote this. For all these reasons, the vaccine plus approach should be adopted globally. So they've very thoroughly shown like, hey, look, vaccines only, not going to work. Missed the F. This strategy will slow the emergence of new variants and ensure they exist in low transmission background where they can be controlled by effective public health measures while allowing everyone, including those clinically vulnerable, to go about their lives more freely. And that's a very important statement, is that when governments are saying, oh, it only impacts people that are medically compromised or immunocompromised or disabled or the elderly, or the very, very young, then like they're just like being like, we don't really care about those people. And when you're just throwing these people out, like if you benefit all the populations by like having these good, effective public health measures, then you're making life bearable for everyone, especially those that like are already vulnerable to begin with. Wanted to stitch the video. Yeah, you can't stitch a stitch, but what you can do, if you write a comment in the video, you can reply to your comments in the video or reply to someone else's comment in the video, and that's a way to get around stitching a stitch. She's vaccinated and used to mask, but they relaxed too much since late 2022. Yeah, no problem. Yeah, I figured it out a while back when I was getting really frustrated because I really wanted to have that reference to that video. And I was like, oh my God, I can reply to a comment. And then, yeah, so you can actually make a super long string of stitching stitches by doing reply comments, and then someone else can stitch your reply comment, and then you can just create a chain that way. So we welcome the World Health Organization's recent guidance on community and healthcare mask use, but believe more can be done to suppress transmission without adversely impacting economic or social activity. Accordingly, we call upon the World Health Organization and national governments to, 1, unequivocally declare COVID an airborne pathogen. So remember, this was in 2021. We have finally admitted it is an airborne pathogen, but people are still against fomite transmission. That's the second thing that we have to really make clear. But it's really funny because they're really focusing on hand washing right now, which is admitting that fomite transmission exists, but they won't actually come out and say it. So to me, that's just like a karmically funny thing that exists. They are so focused on droplet. Yeah. And like the thing is, droplets are both aerosolized and non-aerosolized, and like we know that people can like it's very clear that the non-aerosolized droplets are infectious, and you can get COVID from those droplets. So clearly, fomite exists, and is a way you can get it. Yet we're doing nothing to make that public knowledge, and we're doing nothing really to work on improving measures against that, because that would involve people having to pay janitorial staff to do these mass cleanings every single day in offices and hospitals. You'd have to improve all the stuff. You'd have to stock hand sanitizer everywhere like they did very early on in the pandemic. And it's just like things that employers don't want to do because that costs money. But so we have moved since 2021. We have finally declared it as an airborne pathogen. Promote the use of high quality face masks for indoor gatherings and other high transmission settings. We still haven't done that. Yeah, N95s, KF94s. I don't know what a P2FFP is, but yeah. And they should be preferred in all indoor settings where people mix, and for healthcare workers at the same time, which these days, radical statement. But that should be something. Universal masking needs to be forced on healthcare workers. Advice on effective ventilation and filtration of air. Yep. Again, 2021. And if they use bleach, it can actually stabilize the virus better in the air. Can you say more about that? I don't know what you mean. It is time to go beyond opening windows and aim for it. The CDC just put out a statement. Yeah, you can open windows. It is time to go beyond opening windows and aim for a paradigm shift to ensure all public buildings are optimally designed. Man, I love this author. Built and adapted to utilized for maximizing clean air for occupants. And again, back in 2021, it's already been shown that doing this reduces COVID transmission. So setting criteria for imposing or relaxing measures to reduce COVID spread based on levels of transmission in the community. So this is something that was like a concept early on, is that you increase the level of precautions when you see higher levels of community transmission. So they're trying to do a risk evaluation thing. So like when there's high transmission, high precautions, low transmission, you can relax precautions. But we took that too far, and now people that want to stay safe have to do precautions at all times, while everyone else just does unmitigated spread. So that's what that is. So unfortunately, at this point, we have to like swing the pendulum really far back in the other way, and would have to do like super strong mask mandates to be able to get back to where we could get to a level to do this recommendation. So unfortunately, that's not going to be sufficient any longer. Support urgent measures to achieve global vaccine equity. That's big, including vaccine sharing, suspension of vaccine patents, removal of barriers to technology transfer, and establishing. So like this is where this is one of those things where I've been saying that we need to have a globalized approach to this, because there's huge barriers, like having the technology to store the vaccines you need for Moderna and Pfizer. The mRNA-based vaccines, you need freezing temperatures, not refrigeration temperatures. You need it between like -20, -50 degrees Celsius, which is not something that every like pharmacy, local hospital in other countries has access to, which is why Novavax has been approved globally, and why it's going to be very beneficial for global populations, even though I don't really like the protein-based one versus the mRNA-based one. I think the mRNA is superior. That's my personal opinion. But it's very beneficial to have this because you can use refrigeration temperatures for Novavax, which means that it increases the availability globally, which is something we need. And so like ways you can make things more accessible globally is to have the government take over the patents for this, since they provided the technology and everything else. So if you don't have patents, then you don't have to worry about not being able to having to get like patent approval in all these different countries before you release it. It gets rid of these layers of bureaucracy. Sharing technology openly, as opposed to like being like, we're going to lock all our resources down, you have to pay us to get it. Yeah. And then like having like a global bank of vaccines, like giving the WHO like a huge storehouse warehouse of vaccines that they can distribute globally to have people do this. So that's the sort of stuff that would have to happen. Yeah, I've been ignoring comments, but I have to read some comments. So first comments: my friend who's had COVID multiple times had a stroke. Yeah, I'm sorry. Every once in a while, people get weird stuff that get filtered out, and they're not my filters. Something's happening on TikTok Live. Like a couple lives ago, some person couldn't type the word "scary," so maybe that's why one of those words that you had to do the O's in the letters for might have been blocked. And sometimes it's just for one person. Like other people could write the word "scary," but the one person couldn't write the word "scary." I did a video about it, but a study showed that surface cleaning with bleach reduced byproducts in air. Yeah. Whoa, sorry, I didn't mean to yell. Yeah, so I completely believe that, because if you have droplets and the droplets are drying, part of those droplets are going to be re-aerosolized. So if you clean surfaces, you're going to be preventing that from re-aerosolizing as the it evaporates or becomes small enough to become airborne again. Yeah, bleach irritates the lungs too. The house for everyday cleaning like 15 years ago. I take Patrick in the bin. Ultimately, bleach emits chlorine gas that, once contact with aerosol. How quickly have you seen rapid dark red go to negative? I'm guessing you mean rapid antigen test. I don't know. I haven't seen lots of stuff. But if it's slow. It's not a quick process to go from positive to negative. If you see something like that, it's likely that the rapid test you took was damaged or not appropriate. What you should see is it goes from very dark to lighter, super light, gone over time. So it's more likely that if you went from a very, very dark to a no signal, that it's not that you're negative, it's that the test was faulty. The only one that is approved right now for over-the-counter use is Flowflex. I haven't seen anyone other rapid antigen tests get approved for over-the-counter use, which means that it meets all of the FDA criteria. And it's the only one that's had a consistently high level of sensitivity, because they target both the S protein and the N protein of COVID, which is why they've been able to retain such high sensitivity, in my opinion, for so long. So definitely try to get the Flowflex test if you can. They're pretty affordable on Amazon. I get packs of 5 for like $20, usually like $17.99. The 2 packs are a ripoff. I only got these once because they were out of the 5 packs, but the 2 packs are like $12 for just 2 of them, when you can get a 5 pack for like $18. But it seems like they are back in stock again, because I was able to get some, and they come pretty quick. I have been able to get them the same day, because I have the Amazon Prime. The chlorine gas turns into... Sorry, my jaw locked up a little bit there. Don't know if you could hear it click, but there we go. But chlorine gas turns into hydrochloric acid, which stabilizes the pH of infectious aerosols. I'd have to look into that more. I don't necessarily believe that from my chemistry knowledge. To me, so when things turn from liquid to gas, or all right, so there's two things happening. So you have the chlorine bubbles that are going in the air. You have the hydrochloric acid, which sort of stabilizes the pH. No, that effect would only happen for very, very small periods of time. I don't think I'd have to read through your paper on that. I don't think that's a true risk. But if you did not treat anything and you just left it, I think there is a risk of re-aerosolizing liquid droplets that are just sitting there. As the droplets dry, part of it will be re-aerosolized. So I think that's more a risk. I don't necessarily believe that based on my chemistry knowledge, but I could be wrong. I'll definitely like look into it because it's interesting. But my initial impression is probably not. My husband last year was 4 days. We had all our vaccines on time, therefore making it infectious longer. They did not see the effect either ammonia though. So ammonia doesn't do anything to kill COVID. There's been lots of studies on that. So they actually recommend don't using ammonia. I think that's the point you're making, but I wasn't sure. So ammonia won't kill COVID. Windex doesn't have the bleach in it, so that won't kill COVID. So they don't recommend using ammonia or like Windex to clean the surfaces that are contaminated with COVID. It's really just the bleach chemicals that will kill the COVID, the chlorine. Thank you. I tested faint positive Tuesday and still pretty dark today, but I haven't ever had symptoms. Yeah, that's you can be asymptomatic. But after you test negative for 48 hours, 2 separate tests, still keep masking for a period of time after that because we don't know how long people are infectious after the rapid tests are no longer able to detect because there's a sensitivity level. There's like an initial detection level that has to be hit. So once the virus goes below that, there's still going to be virus for its period of time after that that's infectious, but we don't know how long that lasts for. So keep masking after that for a decent period of time. I didn't mean to write either. I meant though, scrolling back up. They did not see this effect though with ammonia though. Okay, yeah. Completely agree. Tagged you, thank you. I will look at it later. Anything I can do to help kill it faster, eliminate it from my body faster. Yeah, so there's a couple different things that have been shown to work to help reduce the duration of it and to decrease your own personal viral levels. There's CPC mouthwash. This can be ACT mouthwash. This can be Colgate mouthwash that so long as it says cetylpyridinium chloride in the ingredients, gargle with that. It'll reduce the amount of viral virions that you're shedding for a period of time afterwards. The estimates for like an hour or two. I think it's probably shorter than that, but that'll help to reduce the viral load. So you could do that like 3 times a day, like morning, lunch, dinner, after dinner, before bed. So that's one thing. The nitric oxide nasal sprays, they will do nothing to prevent infection for people that don't have COVID, but for people that do have COVID, they recommend using it 3 to 6 times a day, depending on the nitric oxide nasal spray. I did a couple of reviews like this before on those. You can look back on my YouTube and go through the TikTok live recordings. I did 3 papers. The first 2 are on the nitric oxide nasal sprays. and the ones that were taking it 8 hours apart, and then ones that were taking it 3 or 4 hours apart between each spray, doing 2 sprays each nostril. And they were able to reduce viral load from the people that have the COVID, and they were clearing the virus on average like 2 to 3 days faster. So that's another thing that you can do. I think it's called Inovid, but let me Google it real quick. Nasal spray nitric oxide. There's 3 of them. There's Covixel, Norazite, and I think, Inovid is the other one. Let me just double check it's a nitric oxide one. Yeah, an Inovid. So Inovid, that one just has a fun name. So does Covixel. Covixel and Norazite. You can get it on Amazon. All these things are publicly available ones. Yep, CPC. So let me type it in the comment. Cetyl pyridinium chloride, and that's in ACT and Colgate. Yeah, saline rinses can help too. And then some people gargle with salt water. But I haven't looked into those ones, so I can't speak on it. I can only speak on the things I've actually looked into. But I myself will use the CPC chloride mouthwashes. I was trying Colgate. I don't like Colgate. I like ACT a lot better than I like Colgate personally. But I use it in the morning and at night. Yeah. Yeah, and it seems like they help to reduce it over time. If you're doing, yes, definitely use distilled water. Sometimes like things like tap water can have bacteria and stuff in it, which could get you sick. And they're not always necessarily sterile, so they can like not just have like bacteria and things like that in it, but like some of the chemicals that naturally exist in our tap water can be harmful in our nasal passageways and can cause reactions. So yeah, definitely do that. Cool. So global vaccine rollout should include coordinated efforts to tackle misinformation. Oh boy, that's a big one. So the thing that pisses me off the most about the CDC and the FDA is that they barely have done anything to tackle the misinformation, disinformation, especially by some of their own people, like Dr. Ledap. I want to say Ledapu because that's what I like calling him, but it's Ledapo. I just don't respect him, so I don't like calling him by his actual name. But he's the Florida Surgeon General, and he constantly spreads vaccine and misinformation, disinformation. Yet the FDA just like 2 days ago finally sent a response letter to him, because he literally sent a disinformation letter to the FDA on vaccines. And they finally said something back. CDC hasn't said anything about this dude. And the FDA, this is the first time, and he's been saying stuff for years now. And he even recently, like when the new vaccine, the XBB 1.5 vaccine, the 2023-2024 vaccine that got approved this year came out, he went against the Advisory Council for Immunization Practices and told all Florida residents that if you are not an elderly person, if you are not an immunocompromised person, do not get vaccinated. It is harmful to you, is what he literally said. And the CDC FDA didn't say a dang thing about that. So having these coordinated efforts to tackle that type of misinformation is really big and important. And then they're just saying that this is affordable and achievable, which it is. Need to be very clear, vaccines alone will not get any country out of this crisis. Yep, that's why we're going into year 5. Countries can and must prevent the spread of Omicron with measures that work today. It's not vaccines instead of masks. It's not vaccines instead of social distancing. It's not vaccines instead of ventilation or hand hygiene. Do it all. Do it consistently. Do it well. Fantastic quote. I'm going to say it again without stumbling over my words. It's not vaccines instead of masks. It's not vaccines instead of distancing, social distancing. It's not vaccines instead of ventilation or hand hygiene. Do it all, do it consistently, and do it well. They have participated in the misinformation several times. Yes, they have. Largely, like with what Biden was saying, like, get vaccinated and you don't have to do anything. You don't have to wear a mask. You're completely protected. And then Rochelle Walensky said something similar to that. Andy Cohen, again, is doing similar stuff because she is a politician and not an actual public health official, in my opinion. And yeah, Ladapo literally was found manipulating it. The way they phrase it is he cherry-picked the evidence to push a political agenda. But he literally manipulated data from studies to prove a point. Yeah, here, let me show you. So this bottle right here, but let me just show you so that you're going to be looking for, can you see my mouse? Yes, you can see my mouse. Right here, this one, acetylpyridinium chloride. And it's going to be in this bottle of the mouthwash. It's the blue one. And then also Colgate. They actually have a red sticker on the top of the new Colgate bottles that I saw in stores, where it says CPC. Let me just find it. So Colgate. So it'll have right here in the top, active ingredient CPC. That's actually a direct COVID call out because they're saying, hey, we have this ingredient that will help fight COVID. So while they're not saying like helps fight COVID on the bottle, that's basically what this big red sticker is for. Honestly, thank you. My doctor won't get back to me about anything. Yeah, I'm really sorry about that. A lot of doctors are not doing a great job right now. I've had lots of people message me being like their doctor won't prescribe them the Paxlovid. I've had a couple people tell me that the reason doctor wouldn't do it is because they're quote unquote not sick enough. So it seems like doctors are trying to conserve Paxlovid resources. Yeah, I was told no on that med. Yeah, and you shouldn't be. Anyone can get that is able to get Paxlovid can get Paxlovid. So like there are some limitations, like if you're under 96 pounds, so if you're a child, you can't get it. If you're under 96 pounds, if you have a dairy allergy. So a lot of people will have to discontinue their medications for the 5 days that they're on it. And for some people, they can't do that. Like my partner had to stop the, what is it called? The anti-pregnancy pill, the birth control. She had to stop birth control, her anxiety meds, and Adderall while she was on the Paxlovid. So like those are the types of things that you wouldn't be able to take when you're on Paxlovid, because it essentially amplifies the effects of the medications, which can be very bad. Reminder to drink water. So long as like your doctor thinks it's okay to like go off your meds for a short period of time, which like I think the trade-off is completely fine, and you are the correct weight, you don't have a dairy allergy, then anyone should get on should be on Paxlovid, or everyone should be on Paxlovid that's able to. And ways to get around it: there's the test to treat program. There is, which if you're sick, you should be able to get Paxlovid for free. And that's for uninsured, underinsured, and also like people with insurance. So you should still be able to get it even like with insurance. That's something the government's running. So testtotreat.org is one. If you go to an urgent care will prescribe you Paxlovid. You don't have to go through PCP for that. And then the other way is, I forget, but there's a third way to get Paxlovid that I'm spacing on. Then again, I was so sick that I probably wasn't taking it anyway. I don't know what you mean. When is the next booster? The next booster is not until... So this is semantics, but they're technically... A booster is good for boosting your immunity, and our immunity is completely gone within 6 months from receiving the vaccine. So it's no longer a booster, it's a new vaccination. That's just a semantics thing, but I know the essence of your question. So the next vaccine is not going to be until around November of next year, because they are doing a yearly vaccine schedule. The way that I am looking to get around it, and I think that this is going to be a very viable thing to do, is, especially since they're not doing the COVID cards anymore, is I got my Moderna Pfizer vaccine. So I got the Pfizer one when it came out. I'm going to get Novavax. I'm going to try to get Novavax in 6 months and boost my immunity that way, because they're not going to have my records for that, because they're not really tracking that in the systems anymore. So I'm going to try to get boosted, which would be a booster then, because it would be within that 6 month period. What is it? So I got it a month and a half ago, 2 months ago. So 2 and then 4. So around April is when I'll go and try that method, and I'll let you know how it goes. But I'm going to try and get Novavax as a booster. And that's the end of that one. So yeah, this person, very, very great. Save those. And then I'll transfer these over. Close all tabs into my RUD folder. Then I'm going to do a quick pause and then start for the next one. Who's the author? That was the author that I think you turned me on to. I think if I go to one of these ones right above it, Leonardi, I think. Does that ring a bell? Because you had told me about this author, and I was like, oh yes, Leonardi. I found his 3 papers, and he wrote that in 2021, where I was like, oh, I definitely want to read this. So that was like a public plea letter, a white paper that he published to try and like plead with the world to be like, please do this. So yeah, so I have those ones right here. It should be these 3. Are these 2 are the same? No, they're just 2 different ones. Or maybe 4 papers. It's probably 4 papers. Yeah, Leonardi. So 4 papers. So yeah, that was him. So I think so So I have three papers on vaccines because there was a really interesting question from a person on YouTube who's concerned about viral, or not viral, the mRNA clearance. He's like, what stops the mRNA from just being replicated forever and ever? And I was like, I know these vague things, but I haven't looked specifically at how the mRNA gets cleared after it's being read and how many times it can be like reread to reproduce more spike proteins. And I was like, I'll get back to you on that. And then, so like these three papers right here are on that. And then these ones are on the Leonardi's stuff that Christina turned me on to. You just join? What's the deal with the mouthwash? So yeah, so the mouthwash can help reduce viral load if you have a COVID infection. So that can help to prevent spread to other people for a short period of time. I have a paper on it that I haven't read yet for that, where they looked at like the in vivo efficacy of it with a living person. But I know it does work. I don't know how long the effect is sustained, but it is something that people can incorporate into their routines to it's not going to really prevent you from getting COVID, but if you get COVID, it can help reduce your viral load for periods of time to help prevent the spread of it, reduce the likelihood for at least a short period of time. So yep, no problem. So I am going to, I think, start with this Leonardi one, but I'm going to do a quick pause on the live real quick. I thought that all sounded super familiar. I wanted to verify. Yeah, I thought like I wanted to at least get through the white papers in this start, but yeah, that was him. That was him. So I'm going to pause real quick, do a couple things, and then I'll restart the live in about 5 minutes. When I'm goofing the spray, when I'm using the spray, what do I type in for general? Googling. Yeah, either Innovid or the other two that I showed you. So if you just type that into Google, you should be able to link. So really it's just like the nitric oxide spray is what you want to help reduce the viral load for having the COVID infection. It looks like they're kind of expensive, but Innovid is the big brand name one that I'm aware of. Cool. Pause real quick and I'll be right back. Or yeah, sorry, I'll stay on real quick. Xlear is cheaper. Let me just double check that's a nitric oxide one. That one doesn't have the nitric oxide. That's a xylitol-based one. I'm not sure about xylitol, so I can't advocate for that one yet. I still would have to read on that. But I do know that the nitric oxide is effective at reducing the viral load, but you do have to do repeated sprays throughout the day. So I can't advocate for the xylitol-based one yet, but I will read papers on that at some point in the future. Yes, I just don't like speaking outside of things I know about, so that's why I'm phrasing it like that. Cool. I'll be back in a little bit. Gotta let my dogs out real quick, but I'll be right back. Got water. I don't need coffee yet. And then I'm gonna fill up some water, and then I'll be good to go. Okay. It looks a little small. That looks good. Is he going over the Superantigen article now? Yes. So this one is from Leonardi. It's on superantigens and COVID. So the abstract is, it has been posited that COVID contains at least one unique superantigen-like motif not found in any other SARS or endemic coronavirus. Superantigens are potent antigens that can send the immune system into overdrive. So this is essentially saying that you're defining it as a superantigen when you have something that not only can bind and attach to things in your body, but will stimulate the immune system in such a way that it gets really upset that it exists in your body. So COVID can... Nice. My partner's brother and her brother's wife is there. Gross. Talking about their kitten. So COVID causes many of the biological and clinical consequences of a superantigen, and in context of reinfection and waning immunity, it is important to better understand the impact of a widely circulating airborne pathogen that may be a superantigen-like, or trigger a superantigenic host response. Highlight that. Urgent research is needed to better understand the long-term risks being taken by governments whose policies enable widespread transmission of a potential superantigenic pathogen, and to more clearly define the vaccination and public health policies needed to protect against the consequences of repeat exposure to the pathogen. And then let me just save this real quick, or else something terrible happens and I lose access to the computer. I have to restart. I won't lose my work. It's like it holds the floodgate open to allowing naive T cells to release. Yes, and we will learn about that shortly. Or I don't know yet. I'm just taking your word for it for now until I learn. So the first one, what is a superantigen? So this term was coined in 1989 and defined proteins and that hyperstimulate T cells via the cross-linking of T cell receptors. So a superantigen are proteins that hyperstimulate T cells by cross-linking of T receptors with MHC Class 2 molecules. What is MHC? Did we define that already? We did not. To the Google sphere. MHC receptors. Oh my god, they're already barking. Major histocompatibility complex. Okay. The definition was expanded following the discovery of B-cell superantigens. So not only can you have T-cell superantigens, you can have B-cell superantigens, which hyperstimulate a large population of B cells, but without the cross-link. So there's two different things that it can be a superantigen for. It can be a superantigen to T cells. It can be a superantigen to B cells. But maybe it can also be a superantigen to both. There's MHC1 and MHC2. A superantigen is commonly defined as a molecule that has antigen receptor mediated interactions with over 5% of the lymphocyte pool. That's interesting. So it sort of has to be a widespread effect for this to be considered a superantigen. If it has a focal effect, then it's saying it's not, or a local effect. Put simply, superantigens are potent antigens that can send the immune system into overdrive and stimulate up to 30% of the naive T cell pool. Oh, that's interesting, of the naive T cell pool. So these are T cells that have yet to be differentiated. Reactions between superantigens and T cells may lead to a number of outcomes, including anergy. That's a new word for me. Absence of the normal immune response to a particular antigen or allergen. Anergy is a state of global immunologic unresponsiveness, which can be remedied by removal or addition of one or more factors. An abundance of interleukin 10 leads to downregulated blah, 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 blah. Here we go. This is a really simple one. So anergy is a condition in which the body fails to react to an antigen. So that's very important. We're going to make that green. So reactions between superantigens and T cells may lead to a number of outcomes, such as the immune system not even responding to the superantigen, inflammation, cytotoxicity. So that's just, it has the word toxicity to the cytosol. Let me just double check. Now I'm blanking. I know this word, cytotoxicity. Because when you're cytotoxic to a cell, you're like destroying the cell with a chemical process, but what is the simple way to say this? Okay, just toxic to cells. That's the simple way. So energy, so you don't stimulate an immune response, you have inflammation, your body swells, you have like sort of like this reaction, cytotoxicity, you're toxic to cells, and deletion of T cells and autoimmunity. So it destroys T cells too. So that's the simple way to put it there. And then superantigens have also been shown to impair post-vaccination memory. So, interesting. So if COVID is a superantigen, we're gonna make that light blue, your post-vaccination memory cells, so your B cells that have been generated from vaccines, will also not be activated to the superantigen. Because MHC1 is impressed. Yes, we're learning, or I'm learning. You already know. So that's really, really important, is that if it's a superantigen, not only does it do these things, but for people that are post-vaccine that don't have that active vaccine response because it's been too long, they haven't been up to date on their vaccines, then only those like memory B cells are going to be what's activating, and those aren't even going to be activated when you get infected with a superantigen. So the same superantigen can produce a range of host responses. Toxic shock has been shown to develop more severely in individuals who express certain, already forgot, multi-MH. Major histocompatibility complex, class 2 haplotypes, which bind specific to superantigens, which binds specific superantigens compared to with those who express haplotypes with lower binding affinity. Okay. And then responses may also be affected by environmental factors. For example, simultaneous bacterial and viral infections have been shown to increase the effects of superantigen. So that's pretty interesting. So that's actually very interesting. So if COVID is a superantigen, and we know like people are getting like this, we're seeing this crazy multi-inflammatory syndrome in children, MIS-C, and we're also seeing these things that the like right now that the World Health Organization and the CDC have been going like, oh my God, there's these crazy things that are happening in children, and with infections right now that we're sending out an alert for, but it's things that are already known, like there's no new disease. Well, it's because these simultaneous viral infections could be amplifying the effect. So if you have flu and COVID, or the pneumococcal pneumonia and COVID, it's going to increase the effects of these superantigens, which means you're not going to have the immune response. You're going to have inflammation. You're going to have this suppression of your immune system all at the same time. So it already, just starting in the abstract in the definitions page, it's already potentially giving us an explanation for what we're seeing currently with this explosion of issues right now, especially within children. My dad's calling. I'll call him back later. Is today Christmas? It's not Christmas today. I forget when that paper was published, 2022 or 2021. 2022. We're still in the beginning, so it's right there. It was published March 23rd, 2022. So again, this guy, very forward-looking, especially with like that one his white paper we read, but even this one. And I remember you were showing tweets of him being like, I told you all, I told you. And if anyone deserves it, it's definitely this dude, to say that, because basically he predicted this current situation with the multi-inflammatory syndrome in children, this explosion of the white lung syndrome and pneumococcal pneumonia. Yeah, that's pretty it's interesting reading this right now with the current context. So superantigens have been shown to impact the central nervous system function and are implicated in the development of neurologic conditions. Yes, we've already seen tons of stuff with the brain. I'm just gonna make that yellow. Oh, that's the wrong yellow. Control S. Yeah, they attacked him ruthlessly. He said they would be reinfections, and those reinfections wouldn't necessarily be protective. Yeah, and it looks like dude was spot on the money with his superantigen concept, or not his concept, but his hypothesis, because we haven't seen that people having this population immunity from reinfections, from infections, we haven't seen that that's contributed to a lower incidence of the disease. We were actually seeing it accelerating and becoming worse and worse over time, where that's why I made that prediction like 4 months ago that we're going to see the worst COVID wave this winter that we've probably seen throughout the entire pandemic. I was putting the estimate in my head like 60% that we were going to have a significant escape variant. I initially thought it was going to be a Delta variant, but we got a BA 2.86 one. But yeah, and with this knowledge here that we're learning right now, it sort of supports all of that, why we're not seeing significant protection. Yeah, I was right on the money, but this dude beat me by years. Superantigens have diverse. Sorry, just sat on my balls. Superantigens have diverse interactions with the multihistamine. That's not right. I'm going to learn this word. Major histocompatibility complex. Class 2 and T cell receptor molecules involving a number of different interaction surfaces and stoichiometries. That's just a fancy word for chemical configurations. In addition to superantigens, there are superantigen-like proteins that activate lymphocytes using mechanisms that place them outside the superantigen. Okay, I'm going to highlight that. That's interesting. So there are superantigen-like proteins that activate lymphocytes using mechanisms that place them outside the superantigen classification. So it's going to be interesting when they tell us in the next few sentences what this sub-superantigen-like classification is. Luckily, I don't have that issue. What issue? Superantigen-like proteins have been implicated in inducing thrombotic and bleeding complications through platelet activate. Ooh, this is piecing in. Oh, I love this, man. Dude's gonna be like my little bromance. But so all that stuff we've been seeing with the hyperactivation of platelets and how they sort of form around these fibrotic complexes are forming around COVID particles. Is part of the superantigen classification of this overactive immune response. And like we've done tons of paper reviews on the blood, because I'm very interested in the blood. I work in the field with blood. My current job is with heart pumps, and I've been warning my company that I think this is going to become a very, very big issue in the near future. I haven't been able to win support yet for this, but I think we're going to see more and more of the issues moving forward, where heart pumps might cause some issues because of this fibrotic clotting, where it could even gum up the blades in the pumps. But I digress. So yeah, we see this. We do see the thrombosis for people hanging out. Thrombosis is basically you can form a clot, and this clot can be thrown. That's a thrombus when it's being thrown different places. It's a free-floating clot. In bleeding complications, I haven't looked too far into this with the bleeding complications, because technically if you have hyperactivation of platelets, I would imagine your clotting time would be much shorter. So I feel like the issue might actually be less so like bleeding too much, but more like causing obstructive structures when you're clotting from the bleeding. But that's something I still would have to look into. You love him too. Yeah, this dude already, I'm loving him. He is piecing a piece of the puzzle in, which is why I'm like doing this broad ping around with all this reading to get like, because like we've done like tons of stuff, blood, brain, etc. And this is a very important piece to the puzzle where it's explaining why we're having these crazy blood effects. So COVID. COVID causes many of the biological and clinical consequences of a superantigen, and we believe in the context of reinfection waning immunity, it's important to better understand the impact of a widely circulating airborne pathogen that may be a superantigen-like, or trigger a superantigenic host response. Next, they're going to give us a little history. So, lessons from dengue. So, T lymphocyte activation during dengue infection is thought to contribute to the pathogenesis of dengue hemorrhagic fever, DHF. In fact, the dengue virus, ENV, why didn't they just do DV, causes some of the clinical characteristics seen in COVID, including T cell activation, neurologic complications, and autoimmunity. Dengue virus-induced autoantibodies against endothelial cells, platelets, and coagular molecules lead to the abnormal activation or dysfunction. A study of TCR v beta, I don't know what they're referencing there, gene usage in children with dengue virus infection concluded dengue is not a superantigen, but rather a conventional antigen. Okay, so why are you telling us about this? The authors of the study cautioned their findings had limitations, but it's widely accepted that the dengue virus is a conventional antigen that causes host. Oh, you're giving us an example of antigen, superantigen-like. Okay. A conventional antigen can still trigger a superantigenic host response. A recent study of the response of human endogenous retrovirus, HERV, to dengue serotype 2 infection found significant differentiation in expression during infection. So next we're looking at human endogenous retrovirus. Now I'll just, for when I'm reading this in the future, I'm like, what's dengue? Human endogenous retrovirus are, I skipped. Nope, I already read that. Human endogenous retroviruses are components of the human genome that likely originated through the historic incorporation of exogenous viruses. So this is a little throwback to evolution. Some people think that how we became so complex is that we actually started off as single cell organisms that turned into multi-cell organisms, and then how these multi-cell organisms sort of integrated more things is through retrovirus integration, where viruses inserted their genetic code and it became a symbiotic relationship, and that's how we developed these multi-system stuff and became so complex. So I think it's just a throwback to that. So anyways, the human endogenous retrovirus perform important biological functions, but are also implicated in the development of autoimmunity and cancer. Certain viral infections have been shown to trigger human endogenous retroviruses, upregulation and autoimmunity. Human endogenous retroviruses can present proteins that act as superantigens, so that's important. Man, so many people are texting me right now. The Epstein-Barr virus has been shown to transactivate, which encodes a superantigen. This may have clinical implications. For example, HERV, human endogenous retrovirus K18, which encodes is significantly elevated in the peripheral blood of patients with juvenile rheumatoid arthritis. So that could be something that is causing arthritis. We've seen arthritis in children even. So if they have Epstein-Barr virus in the child and the child is getting it reactivated, that could be something that is could be an explanation for the rheumatoid arthritis that the child is experiencing. So that's just an interesting fun fact to know. So the human endogenous retrovirus loci are upregulated by a variety of viral infections, seemingly as part of an effective innate immune response, but it's possible that a dysfunction in response transactivates a superantigen, which triggers an immune cascade or autoimmunity. In fact, transient elevations of human endogenous retrovirus K and prolonged elevation of human endogenous retrovirus W have been found in COVID-19 patients. So they're basically just saying like, hey, we found these things. We know that these things occur when there's a presence of a superantigen. We don't know if COVID is directly causing the superantigen or if like Epstein-Barr reactivation, if it's causing the triggering of something like that already is lying dormant in your body to re-express itself and cause these elevated things, or if COVID is causing it directly, we don't know. But it's evidence that it could be either a superantigen itself or causing the reactivation of things in you, which is generating a superantigenic response. That's what all that word salad is saying. So, superantigens and T cell dysfunction. Sorry, my partner's saying I have to watch this video ASAP, Rocky. It's Taylor Swift. Oh, it's a screen recording. So autistic people and individuals with sensory processing issues after a long day of humaning, and it's a person crawling under a giant sheet of blankets and then pulling this little thing, locking themselves in. Okay. Check mark. Yes. Yes. So, that's sort of what it's saying. My dogs are barking. If they get too crazy, I'll have to put them back inside. My jaw's stiff. So superantigens have differing effects on immature and mature CD4 and CD8 T cells. Superantigens can deplete thymocytes or immature T cells. So I guess that's a fancy word for immature T cells, but I'll double check. But can hyperstimulate mature antigen experienced CD4 and CD8s. So those are T cells. So we're looking at the word thymocytes. So a thymocyte is a lymphocyte within the thymus gland. And then where is the thymus gland? So the thymus gland is that little red thing right here, thymus. So a thymocyte is a lymphocyte within the thymus gland, which exists sort of like in the middle of your chest. So they can deplete thymocytes or immature T cells. So it's not saying they're equivalent. These are two different things that are happening, but can hyperstimulate mature. So we're going to make that green. Antigen experienced CD4s and CD8s. So after hyperstimulation by Staphylococcus and enterotoxin, superantigen T cells can enter a state of unresponsiveness known as energy, where they fail to respond and may sometimes subsequently enter apoptosis or programmed cell death. So not only can, so that's interesting. We're going to highlight that. Make it yellow though. So not only can it decrease the level of, so not only may your immune system not respond, but interaction with these superantigens might even cause your T cells to die. It might just kill them off. And it's not only limited to affecting CD4s by virtue. Superantigens can cause differentiation of naive T cells and stimulation of CD8 memory cells from bystander activation via, that's interesting, bystander activation. What is that? Learning so many new phrases from this guy. Bystander activation. I could guess that it's being activated just because it's within a certain radius or certain distance from it. But I want to know what official definition is. Bystander activation cells. So bystander T cell activation refers to the activation of T cells without antigen recognition. So during an immune response to a pathogen, bystander activation of self-reactive T cells via inflammatory mediators such as cytokines can trigger autoimmune diseases. Okay, cool. So that's saying that not only can you not have the response, but it can cause these naive T cells to differentiate. So it can force them to become part of your innate immunity as opposed to your active immunity, because you'll have this cytokine inflammatory response. So your body knows, hey, something's going on, something's wrong, and it's activating your immune system, but it's not activating your immune system in a specific way to the superantigen, which is not good, because it's basically your body saying, go fight this, but it's not giving a direction of how to fight it. T cells get their name by, oh, I didn't know that. That's good to know. T cells, thymus. Sorry, I believe you, but I just want T cells name. Gotta get it out of images. Because I thought that a lot of the T cells were from the bone marrow. Yeah, T cells are born from hematopoietic stem cells. Oh, you're right. T cells derive their name from thymus. Cool. Oh, okay, so it's the second phase. So they're born from the hematopoietic stem cells from the bone marrow, and they migrate to the thymus gland where they mature, and then that's where they get their name from, the T cells from the thymus. So then do B cells get their name from bone? Bursa of Fabricius in birds. B for bone marrow, yeah. Okay. That's fun. I did not know that. Thank you. How are T cells in the chat doing? Hopefully good. Hopefully our T cells in the chat are doing good. This paper is Superantigens and COVID. It was actually a recommendation from Christina a while back that I'm finally getting to. Very interesting paper so far. Show CD8 T cells that are compromised T cells nearby, but CD8s can't find compromised cells because of the multi-histo complex. God damn it. MHC. I will learn this. Major histocompatibility complex. Suppressed. Yep, cool. So, next, antigen-independent activation or bystander activation of CD8 T cells is a well-studied consequence of viral infections. So this is not new. It's always fun phrasing. I love this. This is a cool graph. So cool. So potential superantigenic or antigenic mechanisms and clinical outcomes. So you could be a superantigen. Examples of this are rabies, Staphylococcus, enterotoxin B. These are encoded superantigen proteins on the actual pathogen itself, and it can cause neurological symptoms like dementia, encephalitis, hormone stimulation, modified behavior, neophobia. Is that a phobia of new experiences? What is that? Neophobia. The fear of anything new or unfamiliar. Interesting. Immunological symptoms, the cytokine storm, lymphocyte differentiation, lymphocyte apoptosis, energy, so I'm not even generating an immune response, and autoimmunity. Cardiovascular symptoms like platelet activation, thrombosis, endothelial-mediated vascular damage, which is all stuff we see with COVID and those cardiovascular symptoms. We see all that with the immunological symptoms, and we see all that with the neurologic symptoms. So these are spot on. Boom, 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 boom. So that does make me believe that this dude is 100% correct, and that COVID is a superantigen. COVID has superantigens. Whether that's the spike protein or the nucleocapsid protein, I don't really know. Hopefully he'll get to that at some point, but something on COVID is a superantigen. The fear of matrix main characters. Matrix main characters. I don't know what you mean by that. Probably a joke I just went over my head. Neo. Oh, Neo in the Matrix. Thank you. It's the autism for me. 1 second, I'll be right back. The dogs are barking real loud. Sorry, I'm not helping science here. I'll be quiet. No, you're fine. It was me. I was taking it literally. What you said literally. Control S. Seb. Oh, we are not responding. Give it a second. No, you're great, Jay. You know how excited I get talking about T cells and COVID. Well, while this is thinking, I can at least open my salad. I splurge and I get the packaged salads. I hate how they rip. I wish I could just rip it in one thing and the whole thing comes off. Remember to eat food. It's great. But I have a timeline. I am going to buy a new computer, provided I still have a job at that point, in April, so that I don't have these issues anymore. I'm more distraction to Patrick, I fear, but it's my happy place and I can't not talk. No, you're fine. This is like, that's sort of like the point of these sessions, is just to like have interaction and get like accountability for me to continue reading the papers, because I think they're really cool and interesting. I like learning. I like showing people how to learn about these things, because like a lot of people get, in my opinion, like, or at least people that I knew in grad school, a lot of times would get overwhelmed by the fact that like, oh, I don't know anything. I don't know any of these words, blah, 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 blah. And I'm like, so what? You have Google, don't you? And like, so like a lot of this stuff is outside of my specific field of expertise, but like I know enough about, like, I have a strong foundation in chemistry, I have a strong foundation in biology. I've literally learned things about that I knew nothing about, and I'm an expert in them, like bones and heart stuff, ACLs, meniscus, These are all things that I've studied to great extent now, and like that's how you become an expert, is by reading about the stuff. And it's a skill you got to polish. Absolutely. I appreciate you showing how to tackle on something like this. Yeah. Well, actually, like the other big thing is like a lot of the big downfall to a lot of the sciences when you have like big new diseases like this is that they don't cross-pollinate. They don't look outside of their hyper-focused niche. Is one issue, and then the second issue is that they just regurgitate stuff. Like in the introduction, a lot of times I'll just be like blah 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 while I'm reading through them, because they're literally just regurgitating the same crap that you see in every single paper. And like it gets to a point where like a person does a study, a person references that study, and then this becomes like the standard, and then people just keep referencing that, even if the information might be inaccurate or out of date or whatever. And you have to like keep updating it. I missed some stuff here. I've been told that staying away from people and wearing masks is going to make my immune system weak. That is not true whatsoever. No, that won't happen. The only thing that is going to make your immune system weak is getting COVID, which literally, I mean, there's other things that can make your immune system weak, but getting the COVID infection will directly impact your immune system. That's why actually what we're looking at right now is the immune system response to COVID, with the postulate here that COVID actually is a superantigen, and we're looking at how it triggers the immune system. Your immune system is always active. You're just not getting viruses trying to attack you. Thanks. James, virus and bacteria make you sick. They don't make you stronger. Yep. I think the person understands, so don't dogpile. Questions are good. It's how we learn. You're welcome. And yeah, just keep, no, you're good. Yeah, it's a very legitimate worry, and we definitely don't want to like hurt everyone's immunity. This is a long delay. Look at the log not respond. I might have to. And that is why we obsessively save. So what I did there is I just did Control-Alt-Delete, and then that opens your task manager, and then you end the task. That's sure. You end the task that's buffering, and then after that you can reopen and have it be fine. So where we were under that image, I think we have to zoom in a little bit so you guys can see it. But yeah, I haven't been sick in 4 years. The last time I was sick was before COVID started. And like obviously that's when I started wearing a mask all the time. But the last time I was sick, I got norovirus, and that I literally thought I was going to die from that. That was absolutely terrible, and that's because someone came in sick to my office. I worked on a fourth floor hallway with medical students that were taking classes down the hall, and someone came and threw up right outside of my office. Came out of my office. I was like, "What's that? That's weird," because it was a weird color. And then I went to see the bathroom, and apparently they had just used the bathroom, got sick in the bathroom, got sick in the floor. So like I got those virus particles, got norovirus within 24 hours, and then absolutely wrecked me. And then now after that incident, I can no longer consume gluten, which is a lifelong change. Kill all my gluten processing bacteria. It's I'm spending all my like free time focusing on COVID, but one of the things that I did want to like eventually read up on was and I've identified papers on this in gluten intolerance after norovirus. And there's lots of evidence out there that getting norovirus can cause gluten intolerance, because I got tested for celiacs and I don't have celiacs, so I'm in the category of non-celiac gluten sensitivity, which is just gluten intolerance. But that virus triggered this thing, and I literally just can't ever eat gluten anymore. And that would be considered a post-viral complication of a thing. And the theory from like when I've like glanced through these articles, I haven't been able to sit down and fully read one like this, because I think this is more important, and that's more just like me chasing my my side quests, my interests. Is that like, because like it just both ends, it literally just killed off all of the bacteria that were my gluten processing bacteria. And we don't really naturally have these gluten processing bacteria, because wheat flour is not something that exists naturally. And it's actually something that a lot of cultures don't even have the proper bacteria to break down and digest wheat flour. It's something that sort of evolved in some European people of European descent that can process it very well, but a lot of people can't process gluten. But I think that like I had like over my lifetime had built up like bacteria specifically that could process gluten, and then after this virus came in and absolutely decimated me, literally almost killed me. And now it can't. Completely changed my gut flora. But sorry, that was a huge aside, all from a buffering moment on the computer. Let me just Control S. So Seb, we were looking up the word Seb because that came out of nowhere. No, it didn't. Staphylococcus enterotoxin B, which is an example right here. Nope. I don't know. It's one of these. So Staphylococcus enterotoxin B, enterotoxin B. Superantigen activates virus-specific CD8 T cells in vivo with both direct TCR. TCR. I don't know what TCR is. They didn't define it. T cell receptor. Okay. Here we go. So superantigen activates virus-specific CD8 T cells in vivo with both direct T cell receptor engagement, in some cases, and by bystander effect. This bystander stimulation is also apparent in vitro. Interestingly, T cell death elicited by superantigenic stimulation is most apparent among the T cells activated by the bystander effect. That is interesting. So, what the heck? So looping back, so when it's stimulating those naive T cells to be differentiate, to just like stimulate like your cytotoxic storm, the inflammation that's triggered from the superantigen or antigen-like thing, where your body's not recognizing, hey, this is the antigen we have to focus on. It's just doing a generalized effect, and then these generalized T cells are going out, and they're just something is happening. They haven't really defined what that is yet, but these patrol units that are just like going out looking for things to kill are being killed themselves. T cell death is being elicited by this superantigenic stimulation. But the interesting thing is going to be how that's happening. But just that it's happening to begin with is interesting. Now I gotta resave it back here since it did that crash. And I saw things were popping in. Your kid's asthma and eczema has improved dramatically. Ooh, quick side note on that. So they found that the reason that that's happening, well, first, like it's blocking off the allergens, but for people that are consistently wearing masks, it's actually improving our lung functionality because it's like resistance training. So when we're not wearing the masks, it's like taking off the weights a little for anime reference, a Rock Lee moment. So your lungs are actually performing better from the masking over long periods of time, and they've actually done studies on this. Is like a thing for, and they found that like people with decreased lung functionality after COVID that consistently were wearing masks following it had markedly better improvement. Like they didn't get full lung functionality back, but compared to people that weren't consistently masking, it was like a 86% improvement versus like a 50% improvement. So it was pretty significant. And these are numbers that I'm trying to recall. Don't quote those ones because I don't know if they're the exact numbers. Hey, hi, Witchy Muse. Really fast, I didn't know that. I'm assuming that's towards the norovirus stuff. Hey. Going through Leonardi's articles. Awesome. I think mask wearing should be recommended to asthmatic as a preventative. Absolutely. Blocking out the allergens themselves that can trigger the asthma, as well as the resistance training. It's been so beneficial. That's something somewhat naturally occurs because we don't ever want CD8 just running around rogue because it can. CD8 are trained to unalive, and if not on tight leash, will cause autoimmune conditions attacking healthy tissue. Yes, definitely. So it'll be interesting. Hopefully I'm sure they will. This guy's very, very detail oriented, so I'm sure he will explain why they're dying. I just like to not make assumptions before. Well, I do make assumptions sometimes, but in this situation, it's going to be very interesting what the cause is or what he spells it out to be. So CD8 T cells, which the superantigen directly stimulates per T cell receptor B chain retain their cytotoxic function. The possibility of deletion of antiviral memory by the bystander effect warrants investigation, as it could compromise microbe clearance. So they're saying, I think he's saying he doesn't know. Chronic exposure to superantigen could continually stimulate T cells, keeping them in a perpetual state between energy and hyperstimulation. Furthermore, given naive T cells can be activated and differentiated by the bystander effect, this could manifest in an observed naive T cell depletion, which we are seeing. We're seeing depletion of naive T cells in the peripheral blood. Involution. Involution. The shrinkage of an organ due to old age. Okay. This effect could explain the paucity of naive T cells in some long COVID patients. The loss of naive T cells is a defining metric in immune aging and dysfunction. Oops. They help regulate immune responses and have the highest expansive capacity in response to antigens from cancers and infections. Very, very interesting. Thymus, atrophied in adulthood. Yes. Yeah, so what Christina's mentioning, so the thymus will naturally age as we get older, and you'll have less of these naive T cells over time. But the thing that's happening is that when you're young and healthy, when you're potentially a child, you have lots and lots and lots of these, they're seeing this aging occurring, which means that you're younger, having a less robust immune system for us that continually get infected. And we don't know what the long-term consequences of this are other than maybe like, well, I guess we do. So we know that this paper is postulating that you'll lose the ability to have these memory T cells, so won't recognize infections that you would have had infections to before, not necessarily just COVID, but to other infections as well. You'll have less of an ability to respond when you are sick, so you're going to be sick longer because you're not going to be able to clear it as fast as you would have prior. And not only are you going to be sick longer, you might not develop immunity to that sickness once you're cleared of it. If you're cleared of it, you could die. But if you're cleared of it, the virus, your immune system might not even develop an appropriate immune response because you don't have enough of these naive T cells to be differentiated to it. And then what else could happen? Yeah, that's pretty much it, which leads to shorter lifespans. It makes things that you would have healed from more severe, more impactful, reduces your long-term lifespan because essentially if you naturally would have lived like 100 years and your immunity is decreasing linearly over time, these are assumptions, then if you're basically like age 10 years, then you're only going to live to like 90 in this theoretic thing. And then if you keep getting reinfected, then you're just going to be popping off years based off of your immune age. Without enough naive T cells, the T cells that we do have start to try to replicate to boost numbers. That's interesting. I'll need to learn more about that. But replication cycles reduce telomeres, T cell exhaustion, and telomeres are how we have, that's our cellular age. They're little caps at the end of our DNA, and the shorter these get over time, they prune our DNA to make sure that we don't have mutations and stuff. So the shorter those caps get, the more prone we are to getting cancers and other issues. And then eventually we'll just like, we won't be replicating appropriately anymore because like all the time our cells have to regenerate and they're not going to be able to change with us, which means we're probably going to die. Yeah. So my throat's a little sore from all the talking, but we're going to get through this, and then I'll have to take a pause. I don't talk most of the week, and then I do these, and my throat just gets all raspy. I could never be a singer, even though I can't sing whatsoever. So, superantigens are implicated in the development of autoimmune diseases. T-cell clones that are cross-reactive towards the endogenous host and microbial epitopes may be stimulated and migrate to tissue containing an autoantigen, a mechanism believed to play a role in the pathogenesis of rheumatic fever. Individuals with autoimmune disease show an increase in such T cells in affected organs or peripheral blood. Superantigens stimulate autoantibodies production by bridging the multi-histologic complex. God damn it. I'm making it my mission to learn this. The major histocompatibility complex. Major histocompatibility complex. Bridging the major histocompatibility complex, class 2 molecule of B cells with the T cell receptors on T cells. Whether deletion or autoimmunity occurs seems to be a function of dose persistence. Deletion of what? I'm not sure what they're referring to with deletion. This is annoying. Come on. I know I can do it. I've seen it. I've seen it in the... We got it. Save. Persistent subcutaneous exposure to a superantigen has been shown to cause a systemic inflammatory disease mimicking systemic lupus erythematosus, SLE, in mice. Superantigens have been shown to trigger or exacerbate systemic lupus erythematosus. Interestingly, HERV-E, human endogenous retrovirus, has been implicated in systemic lupus erythematosus and is found to be upregulated in the bronchoalveolar lavage fluid of COVID-19 patients. I don't know, just basically saying that this is something that can occur in the lungs. It doesn't need to be green. Insulin-dependent diabetes mellitus, IBDM, is a T-cell mediated autoimmune disease triggered by unknown environmental factors acting on predisposing genetic background. So genetics can play a role in this. But there is evidence superantigen-like exposure in the form of human endogenous retroviruses W, E, and V, and upregulation is implicated in the recruitment of macrophages in the pancreas and beta cell dysfunction. Antibodies against the human endogenous retrovirus W, E, and V precede or overlap with conventional IADM, insulin-dependent diabetes mellitus antibodies in use and who are susceptible or have the condition. Okay. Click save. Major, what happens unaliving T cells to stop damaging or allowing T cells to cause damage? Autoimmunity. Yes, that's what it seems like. So COVID as a superantigenic, superantigen-like pathogen, or superantigen trigger. So these are the three different things that COVID can be. Seems like it actually might be at least two of them, where it is actually it might be all three, because it probably has the superantigen, so it's superantigenic. So it would be two actually. It wouldn't be the superantigen-like pathogen. It would be one or the other. So I think it's superantigenic, and then it creates, no, it would just be one of the three, superantigenic. So we note a recent study of COVID which found immunological dysfunction following mild to moderate infection. So again, you don't have to have severe infection for these things to happen. And we've seen papers that say that even after an asymptomatic infection, you can have depletion of your naive T and B cells. And this is also something that happens. So they're showing that you can get long COVID after a mild or moderate infection, which is correlated with your depletion of naive T cells and B cells. And a single cell atlas, which was found depletion of naive T cells and higher levels of apoptotic T cells in SARS-CoV-2 infection than HIV. Whoa. So they're saying that there's more immune dysregulation than even people with HIV. That's crazy. That's a blue. That's a holy mackerel. Taken together with findings on post-COVID autoantibodies, presentation of multi-inflammatory syndrome in children. So that's what we were talking about earlier. Activation and depletion of T cells and a rise of the diabetes. These are suggestive of a superantigen-like protein, or triggering of a superantigen host response as a causative agent, and further research is needed into its role and likely long-term effects. Completely agree. I thought I was over my stiffness. Sorry, just spit out some lettuce. For my gluten reaction, but definitely part of this is stiffness in my jaw. The back stiffness is gone. The shoulders, the knees, the ankles, but it's my jaw. It's weird. Further research is needed, particularly since COVID has been found to persist in the body months after acute infection, and we actually have evidence now that it persists years after infection. And this has been studies in the brain, this has been studies in the pancreas, the liver, kidney, it's in the intestines. It's been found years after infection now. So SARS-CoV-2 superantigenic characteristics have been implicated in multi-inflammatory syndrome in children. It's going to be a green, because we talked about that earlier. We explained why that is. So yeah, this is just more evidence behind that. The expansion of T cells carrying the TRBV112 gene in combination with variable alpha chains, a hallmark of superantigen-mediated T cell activation, has been reported in several studies of patients with MISC. So again, possible genetic component that could contribute to this, but it doesn't mean you necessarily have to have the genetic component for this to happen. I'm just saying that people that have the genetic component have a higher rate of it happening. So Broden offers an energy allocation hypothesis, interesting, suggesting a choice in favor of disease tolerance over maximal resistance. That means children are more likely to present with mild and even asymptomatic disease, but might also be less efficient at viral clearance and ooh, this is very interesting. This is going to be a blue. And consequently be more prone to some level of viral persistence and possible other conditions linked to such viral persistence, such as superantigen-mediated immune activation and multi-inflammatory syndrome in children. So you know how everyone's been saying, oh, COVID doesn't impact children. Oh, COVID is cleared in children very short infection. It doesn't impact them at all. But like we know, children have a very high propensity of getting long COVID. And it seems that even if their like viral infection periods are small, their viral clearance, their ability to completely get the virus out of their system is much lower than adults. And they do not make an immune memory to it. Possibly. Maybe that's in the next few sentences. So we question why such COVID superantigen characteristics would not be assumed to apply to adults, particularly given the clinical and biological manifestations in all age groups. I mean, you probably know more than I do because I'm still reading through this first one, and there's 4 papers. We question why such COVID superantigen characteristics would not be assumed to apply to adults, and also like because like it's real weird that they're saying that it's gonna like, oh yeah, just really old people and really young people, and it's not gonna impact like not really old or really young people. Like, why are we assuming that it's gonna impact different people differently? I guess is the question when we like know these things happen. It's just like it's gonna happen to everyone, particularly given the clinical and biological manifestations in all age groups, which again, love when I am like right on par with the author's thoughts. It's always a very rewarding experience, which reflects known prior differences between responses to superantigen exposure in adults and children. Indeed, multi-inflammatory syndrome in adults manifests in adults as a consequence of SARS-CoV-2 infection. That's interesting. And rare instances of Kawasaki disease are observed in adults. The issue of whether COVID contains a superantigen is not settled, but the evidence accumulating in COVID is causing superantigen or superantigen-like clinical presentations and biomarkers, which I completely agree with. In addition to cytokine storms, T cell activation, deletion. Oh, that's what they mean by deletion. Thank you. So that your comments earlier make sense. T cell deletion is what they meant when they just said deletion. And presentation of multi-inflammatory syndrome in children. So this is a very interesting thing. So this is something that a lot of people can't do well. So like this is exactly the type of thinking. So I'm gonna do an aside with fomite transmission. So a lot of people, because COVID is a respiratory virus and it becomes aerosolized, you can never make the full assumption that the person was infected only by fomite transmission, because there's the possibility that they were infected by the aerosolized agents. So you can't say fomite was the direct cause of the infection. However, that doesn't rule out fomite infection risk. Just because you're around a person and you wiping your hands on your shirt after the interaction and then picking your nose or picking something out of your teeth, and that's how you got the actual infection, it doesn't, like, you can't do like a direct sequence cause to like fully know that was the actual reason that you got the COVID, as opposed to like being in the room and talking to the person. But just because you can't say it's definitive, that doesn't mean you can rule it out, which is incredibly frustrating because some people say, well, you can't prove it, so it doesn't exist. Exactly what he's saying here is because of all of these things, because of the evidence, even though we haven't like done like a study and like definitively proven that COVID is a superantigen or superantigen-like, the fact that there are all of these clinical presentations, there are these biomarkers that we're seeing, there's the cytokine storm that everyone talks about, there's the T cell activation, there's this T cell deletions, there's the fact that it just exists, the multi-inflammatory syndrome in children. This is all evidence that it has either one or the other. And like, it's the looking wide and seeing the forest when people are focused on the trees. So I applaud this author because they can see. A lot of people can't see. it's a very tough skill to develop or to have. They still have intact thymuses, so they did do better initially, but with repeat infection ages. Yep, I still have my direct messages with him telling him about the Miss A. Yeah. And I gotta look, I haven't seen people talk about that. Multi-inflammatory syndrome in adults. I've only seen it Miss C. So that's interesting. And Kawasaki disease is a suspected consequence of superantigen exposure. And those infected by COVID who suffer long COVID follow-on infection manifest symptoms, typically seen in autoimmune conditions such as SLE. I don't remember what it is. I don't feel like scrolling back. And autoantibodies and anti-nuclear antibodies have been detected in a proportion of such individuals. In vitro assessments of COVID superantigen-like region may not capture the full physiological effect on the immune system in vivo. For example, lipopolysaccharides could potentiate the SCD superantigen, which could have a synergistic effect on T cells following gut inflammation. Interesting. Via lipopolysaccharide translocation. So we're talking about the chemistry. And COVID is known to infect gut epithelial cells and persist in the gut. It's 100% true. So we've seen it. It doesn't necessarily exist in the large intestine. We've seen it mostly in the small intestine where the viral reservoirs are. But sometimes it can actually even exist in the anus. They've found it. They've had to do like biopsies of people's buttholes, and they found it there. In disrupt-type junctions and bronchial epithelial barriers, indeed hospitalized non-survivors of COVID infection had increased lipopolysaccharide detected in the blood. Oh, so they're just saying that's a biomarker. Sorry, I thought they were looking at the chemical structures there. Nope, they're just saying that high elevated levels of lipid polysaccharides is potentially an indicator. While COVID may not be canonically superantigenic in vitro, the in vivo consequences may be significant due to other danger and death signals. So they're saying that this is hard. They haven't been able to prove it in a lab, but that doesn't rule out the fact that it could be happening and likely is happening in people. Systemic lupus erythematosus. Thank you. Systemic lupus erythematosus. So with evidence mounting that COVID reactivates latent viruses such as Epstein-Barr, cytomegalovirus, and human endogenous retrovirus, which are associated with superantigen expression, it is important to establish whether COVID is a superantigen or triggering second-order superantigenic responses in susceptible individuals. So is it the chicken or the egg, essentially? Is it directly causing the effects, or is it a secondary characteristic of the infection? So some countries seem willing to tolerate high levels of infection provided their healthcare systems can cope. So that's the US. So the US is saying, we don't care. So long as our health systems don't deteriorate, everything's fine. It's fine. Everything's fine. And this approach is predicated on the belief that a level of protective population immunity. And this approach is predicated on the belief that a level of protective population immunity can be achieved and sustained, and the impact of reinfections will be less severe. And that's not what we're seeing. We're seeing that the impact of infections are more severe, and likely that we cannot achieve population immunity from infections, that they are damaging, that this is not going to be sustainable. It's going to cause very, very big issues. And that if COVID contains a superantigen or superantigen-like protein or triggers a superantigen host response, this strategy may prove a grave error. And that is, yeah, exactly what I just said. And very, very, yeah. So the effect of a superantigen is dependent on dose exposure, genetic predisposition, environmental conditions, and immune response. So what that means is that we have how long you were on the person is your dose exposure when you initially got it. We all have our genetic predispositions, like how getting norovirus, I had the genetic predisposition to becoming gluten intolerant, because I don't have a strong enough European heritage apparently to be able to process gluten. That's an example to try and relate it back in. Environmental conditions, so like how hot is it, how cold is it, things like that. Are you in? That can also mean like your socioeconomic status. Are you able to take time off, etc. And then your immune response, which we are showing is getting worse and worse and worse over time. So as the total population has waning immunity, not just from time since vaccination or time since infection, but from repeated infections, it's going to be getting worse and worse and worse over time. Ain't that the dang truth? Grave error indeed. Yes, yes. Quite a pause-worthy moment when reading it. So, we're getting close to the end. There we go. Conclusion. I was like, man, this paper is going on forever. Thanks for all you're doing. Yeah, no problem. I'm like, for me, just as like a quick like fourth level view or fourth wall break. For me, I'm like, all I'm really doing is just reading papers and sharing it with you guys. Like, I'm not really doing anything, but you're welcome, I guess. So there is evidence that the toxic effects of superantigens can be inhibited by specific antibodies, but protection conferred seems to depend on antibody titer and exposure dose. Recent evidence of reduction in multi-inflammatory system in children following vaccination supports the protective role of antibodies. So, in preventing clinical manifestation of a superantigen-like infection. So this is underpinning the fact that you want to get vaccinated over getting an infection. Getting vaccinated is going to be the most protective thing, and getting vaccinated repeatedly is going to be the most protective and important thing, because especially in these people in the general populace that is getting these repeat infections, they're going to be losing their body's ability to have this the memory B cells, the memory immune response. So your body's going to forget how to protect yourself against this stuff. So having these vaccines, as opposed to getting infected, we should not be advocating as a country for you to get infection. So I always, it drives me absolutely insane when I see these two things bundled into the same sentence, how we have high population level immunity from vaccination and previous infection. Like, no, the previous infection is not doing what we think it's doing. It's actually making things much worse. And like, you don't need to get infected to get an immune response. You should be getting vaccinated, and we should be pushing vaccination. And it should be very clear on why this is important. And COVID clearly a super antigen. I think I could make that statement right now, and based off of this person's writings. So yeah, just more stuff to that. Thanks for doing. I said in 2021-22, infection-based immunity is a farce. Yeah. I don't know when I started saying it, but it's been upsetting me for a while now, because it's just not true. So rather than proving beneficial, allowing widespread transmission of COVID could be detrimental, and the growing population suffering from long COVID, marked by depletion of naive T cells, may be a warning. So that's our big warning bell that he rung in 2022. That if we just keep allowing this this let it rip strategy, I love whoever came up with that. The let it rip strategy that we have, where we're just letting people get infected. Our long COVID numbers are just going to go up, 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 up. Our T cells are going to go down, 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 down. And we're just going to be hurting ourselves in the long run from a population level, let alone individual level. So given the adverse impact Kawasaki disease and some autoimmune conditions can have on long-term health and longevity, national strategies that allow widespread transmission of an airborne, potentially superantigenic or superantigen-like pathogen that has demonstrated some evidence of persistence and can inflict repeat infections may be misguided. That's a fun sentence. I won't highlight that one, but this author is very nice in how they write things. Because like if I had known all this and I had read all this, I would be writing very, very, I don't know, because I know as a scientist you have to write things nicely, but I would be doing I would be yelling about this. If I was him. I always have an appreciation for people that can write things in such eloquent ways, when people are fucking up. Well, that's why he's like, I told you so now. Yeah, here I am, 2020. I have the tweets. Yeah, so yeah, this is just like this paper is in 2022, so I haven't read the other four, but the other four definitely go back to, or the other three definitely go back to around 2020, 2021. I think 2021 was his first published one, but yeah, this dude has been screaming his head off, but people haven't been listening. So, if COVID is a superantigen-like or triggers superantigen host response, the unpredictable nature of superantigen makes it particularly difficult to assess the long-term effects of the virus. Urgent research is needed to confirm or refute the superantigenic nature of COVID to better understand the long-term risks being taken by governments whose policies enable widespread transmission, and to understand whether it is necessary to maintain consistently high levels of neutralizing antibodies, which would mean more frequent vaccinations, to better protect against the consequences of exposure to the pathogen. And that's what I've been saying. That's what lots of people have been saying. Like, I think we should be getting vaccinated 3 or 4 times a year, probably 4 times a year. If we're going to lean into this vaccines first strategy. Yeah. So it is of vital importance to definitely establish whether COVID is a superantigen-like, or triggers superantigenic host response in order to better understand the short and long-term consequences of infection. Oh, sorry, I want this to be blue. It should be noted that one of the superantigen-like motifs posited by COVID is unique and not found in any other SARS or endemic coronavirus, and that according to longitudinal analysis of COVID, this motif appears highly conserved. Cool. Who is the author? It is, well, the first author is Adam Hamdy, but the corresponding author is Anthony Leonardi. So what that means, this is the person that wrote the paper, Adam Hamdy. This is the corresponding author, so this is the person whose lab it was. He's the PI, the person that like leads the long-term focus of the research. But the student, Adam Hamdy, is the one that wrote this paper. Yes. And Christina is why I even read this paper, is because she told me about it and I was like, oh, that's really interesting. I need to learn more about that. So it's 11:46. I'm probably going to take a pause for a couple hours to I don't know, upload this 3-paper recording to YouTube, and then just do some life stuff. But I'll be back later. I want to read a couple more papers. This is great in horror finding. Yep. Very horrifying. But knowledge is power. Yeah, he did. Cool. Well, I'm gonna head out, but I'll be back in a couple hours after I exercise and do some cleaning. Thanks for stopping by. Bye, everyone.